Welcome to Medical Logistics 101, Red Eye Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definition: a red eye is not a diagnosis, of course, it is a symptom. It is the eye's way of saying something is irritated, infected, injured, or dangerously pressurized in the case of acute angle closure glaucoma. The key is separating common and harmless from rare vision threatening causes. Signs and symptoms we, of course, look for in general: redness, burning or irritation, tearing, discharge, light sensitivity, blurred vision. Something in my eye sensation is a common complaint, and of course pain, which can be everything from mild to severe. Exam findings you look for: pattern of redness, is it diffuse versus a limbal flush, discharge type, watery versus purulent, corneal clarity, pupil shape and reactivity to light, photophobia, fluorescein uptake, false negative if delayed. Fluorescein is some of you may have experienced before. Oftentimes when we see these people, we apply topical anesthetic like tetracaine. Then we will apply the fluorescein strip, little orange strip with a sterile solution applied, and the dye, this orange dye, will adhere to punctures, abrasions, corneal ulcers, anything like that on the eye under a special, basically black light that we look at. Of course, intraocular pressure if there's a concern for glaucoma. Even most clinics can quickly check, just a little simple hand tool, check intraocular pressure if there's a concern for glaucoma or a history of glaucoma. Obviously, eyelid swelling and extraocular movements are very important on exam. Dangerous findings. In the case of, go through several of these, acute angle closure glaucoma tend to have a history of severe pain. They often report halos around lights, having kind of a mid-dilated pupil that's not very reactive. Clearly, in this situation, you want to check intraocular pressure, which is going to be very important. That will be helpful, very helpful from a diagnostic standpoint. Nausea and vomiting. If you have a suspicion of acute angle closure glaucoma, these people need urgent ophthalmology evaluation, which can sometimes be a problem if it's nights or weekends. Uveitis and iritis. You typically will get a history of photophobia, consensual pain, ciliary flush, constricted pupil. Typically treat with urgent steroid drops and close follow-up with ophthalmology, sooner rather than later with the follow-up. Corneal ulcer. This one does come up sometimes. Classically associated with severe pain, we'll expect to see a fluorescein uptake on that exam of the cornea. Frequently will give a history of being a contact lens wearer. And that is, like I said, just something associated. If you have severe pain, that history, and they have a history of contact lens use, think corneal ulcers for sure. This one is vision threatening and needs antibiotics immediately. Much more serious than your normal corneal abrasion, minor corneal injury. Corneal ulcers are very serious. Herpes keratitis. Dendritic lesions is typically the source of spread, often recurrent. In this case, antivirals are needed, not steroids. Just as people have the herpes virus, the herpes simplex virus associated with cold sores, remember it's living in the nerves, so it can be the nerves around the eye just as well as it can be around the mouth. Orbital cellulitis, pain with eye movement, fever, proptosis or bulging of the eye, CT scans sometimes done. Again, if you're having proptosis on exam, that is a bulging of the eye, the CT scan would be very helpful in providing better imaging of any edema around the orbit. Also in this patient, usually with orbital cellulitis, it's a very potentially serious cause and loss of vision, and oftentimes we'd be given antibiotics, IV antibiotics for these patients. Dangerous findings continued. Now, get into the injury category: chemical injury and, of course, foreign body and corneal abrasion injuries. Chemical injury is immediate irrigation, including under the lids. Let me emphasize, including under the lids, needs to happen immediately. Alkali burns are worse typically in terms of injury. Time equals vision loss. This is one of those categories you've got to move quickly. Big point here. Pediatric patients will require conscious sedation. That means the ER. You're not going to be able to sedate that patient enough to do the adequate exam and certainly the adequate irrigation in a pediatric patient in a clinic setting like an urgent care or primary care. Precious time, go directly to the ER. And I would say that, with conscious sedation, both adult and pediatric, You've got to be able to closely monitor your airway and prepared if that patient goes from conscious sedation to deep sedation and the airway management that goes with that. So yes, quickly get to the ER in those patients. Foreign body, corneal abrasion, maybe not as time sensitive as a chemical injury, but still sharp pain, photophobia. Would expect to see that fluorescein or dye uptake on exam if it's not delayed. I have seen people before that have a foreign body in their cornea. You do the fluorescein and you're like, there's no uptake of the dye. You're like, well, obviously the foreign body made a puncture wound to be in the cornea. Why is there no fluorescein uptake? Because they waited long enough that the cornea has healed over that foreign body. You can still see the foreign body and it still needs to come out, but there may not be a fluorescein dye uptake because they delayed presenting. Again, with this category, though not as time sensitive as chemical injury, the pediatric patients will require conscious sedation to do an adequate exam and irrigation. That means the ER, not primary care, not urgent care. Common less dangerous causes that we see a lot more of, conjunctivitis, viral, usually tends to be kind of a watery, gritty sensation, bacterial, which is more purulent drainage, and allergic, which is more tends to be itchy and bilateral. You know, all three of those look similar. The discharge in the case of bacterial causes may be a little more purulent, looks a little more suspicious for a bacterial infection, but they all look somewhat similar. These patients oftentimes will get antibiotic drops for their eyes just because there's a concern for missing a bacterial conjunctivitis. Even just a delay of 24 hours would be very significant. So oftentimes, yes, they do receive topical antibiotic drops for the conjunctivitis. And then, of course, subconjunctival hemorrhage. This is more like a blood vessel rupture in the eye. A lot of people have seen this before. Looks scary, generally harmless. No vision changes associated with this. Certainly there's no fever. Wouldn't expect to see any discharge with a subconjunctival hemorrhage. But it looks scary, but usually not serious. Red flags that should immediately prompt someone's concern with red eye, severe pain, vision loss, photophobia, nausea and vomiting with eye pain. That would be unusual. Contact lens use plus pain, I think corneal ulcers until proven otherwise. Trauma, especially in a history of high velocity injury or metal grinding. Someone using a weed eater, something like this. You need to be particularly on guard against those patients. And of course, pupil asymmetry. Disposition, immediate care if there's any red flag present. Same day care if moderate pain, photophobia, or contact lens issues. Follow up within 24 to 48 hours if there's persistent irritation without red flags. You know, this brings up an issue of, no offense to the ophthalmologist and the optometrist, but they tend to have banker hours. So a lot of times these patients may present in the middle of the night. Maybe it's Friday afternoon on a weekend and you're not going to see an eye doctor till Monday. Regardless, if there's any sort of worsening in the condition, worsening symptoms, need urgent reevaluation with these patients. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can afford to miss. Thank you.